Jim Ferguson is a Canadian who has been living in the United States for the past 45 years. Jim's medical career began in Fort Smith and Yellowknife, where he trained as a certified nursing assistant in 1977. After completing 3 years towards a bachelor's degree in nutritional science at the University of New Hampshire in the 1980s, Jim then applied early and was accepted into the Physician Associate Program at Bowman Gray School of Medicine at Wake Forest University, graduating in 1990. Jim has over 32 years' experience in clinical practice in family and emergency medicine, public health, and as a general surgery physician associate. During his career, he has completed a master's in public health from the University of Massachusetts, Amherst. And most recently, he has completed a 2-year fellowship in integrative medicine at the Andrew Weil Center for Integrative Medicine in Arizona. Jim has been a strong advocate of the physician associate profession in Canada for decades. And this morning, he's going to share his thoughts on its value and its place in healthcare. So please welcome Jim Ferguson.
I'm really happy that I've been invited back to come and share some thoughts. How many people here have gone to college? So pretty much most everybody. And when you went to college, were you always taught by the professor? Or did you oftentimes have an associate professor or an assistant professor that presented material to you? Yeah, and most of the heads are shaking up and down. Yeah, and so if you've had an experience work at university or college where you've had associate professors or assistant professors presenting information to you, then you'll sort of appreciate where I'm coming from with this particular presentation on physician associates. First of all, a little bit of history. Let's see if I can get this working properly. There we go. And I can actually see everything right here anyway. So a little bit of history first, and then I'll tell you a little bit about my journey. The physician assistant profession, which started back, it really was conceived mentally in the late 1950s by a physician named Dr. Eugene Stead. And he was at Duke University in North Carolina, prestigious medical school there. And anyway, he came up with this idea that there was a physician shortage in the States at the time, and they were trying to figure out what can we do to provide quality health care for people in areas where there are no physicians. And so anyway, he conceived of this idea of the physician assistant, which is now in modern day called the physician associate. And this concept came to him, and he thought, well, who's going to do this job? Who are we going to train? Well, he thought of the medics in Vietnam, coming back from the Korean War, Vietnam War era, and he thought, these individuals are highly trained medical providers, but they come home, they leave the military, then they have nothing, they have no avenue by which to practice and share their talents, okay? So Dr. Stead thought, that's where we start. We'll start with these medics from Korean War, Vietnam War era, and we'll train them to be extenders of the physician's services. And so at the time, they thought of them as physician extenders. And then Dr. Stead came up with physician assistant. I will say that I've met Dr. Stead. He's long gone from this world, but he spoke to our PA class at Bowman Gray years ago. And he said if he could go back and change one thing, it would be that he would never have called them physician assistants, because they weren't assistants. They were really associates with the physicians. They didn't stand there with somebody looking over their shoulder while they practiced. They were associates. They were colleagues of the physicians. So anyway, he said that was one of his regrets, that he labeled them assistants, because it really set the profession back probably a decade or two, because people just thought of them like they didn't have anything significant to contribute, to healthcare. It's unfortunate, but just the way it was back in those days. But Dr. Stead was really the brainchild of this profession, and the first class graduated from Duke in 1967. There were 3 young men at the time, And I went to Bowman Gray Medical School PA program, and it was either the second or third PA program in the nation. Started in the late 60s, early 70s, and so it was very prestigious, very well established by the time I went there. At the same time as Dr. Stead, there was Dr. Richard Smith, brilliant thinker, physician, and he decided to start a concept called the MEDEX. And this is medical extension, medical extender. And he started his program out at University of Washington in Seattle. Okay, so you had whenever you get more than one person thinking of these things, you think to yourself, there must be, the time is ripe for an idea, for a concept, right? And so anyway, multiple people started thinking of this idea. And Richard Smith was another. His concept of the medical extender, which is like the PA, spread to India, spread to Guyana in South America, spread to countries around the world around that time. And I'll tell you more about that in just a few minutes. So PAs have been in Canada for decades. They're in the military, probably since after the Second World War. They've had some version of the PA in the military. And then they've also established the Canadian Association of Physician Assistants. And they started with programs at McMaster. University of Manitoba was an early program. University of Toronto had a program, or has a program still. And then recently at Dalhousie in Nova Scotia, my home province, I've been in touch with the physician who's directing that program, and have offered to offer my services as to inspire the ranks, so to speak. Let them know that there's a Canadian who actually went through this program years ago. And so anyway. But Dalhousie has a new program, maybe a year or two old now as well. So for me, as Alan mentioned, I started up in Yellowknife and Fort Smith training as a CNA back in 1977. And I was inspired by working with First Nations peoples, and really seeing the need for medical care in these rural areas, right? So you think of Canada and the US border. Where do 90% of the people live? Within 50 kilometers of the border. Most people live in these big cities. But up in Yellowknife, I started to think, well, who's up here? And they had some wonderful physicians and some nurse practitioners at the time in Yellowknife. And around that area, in the Arctic, I went up to Coppermine, and I went up to Inuvik. I went to all these areas. And there was very little in the way of healthcare in some of these remote areas. Obviously, Inuvik had a hospital, small hospital. But point being that I started to think even then, okay, what's the solution here? There's not enough physicians to take care of this problem. What do we do? There's not enough nurse practitioners to fill the gaps. What do we do? Okay, so that's sort of where it began for me. As Alan mentioned, nutritional science and biochemistry. I was in the pre-med program at UNH, and I first heard of the PA profession back then. And I thought, my wife and I at the time we had a little baby, and we had a second child on the way. And I thought, this might be a nice alternative. You get a really solid medical training, and then you can maybe have a balance of life and work at the same time. So I thought maybe I'll look into this, and it seemed like the right path for me to go. So off I went to Bowman Gray. At the time, it was again a rigorous 24-month master's level medical education program. And we rotated with third and fourth year medical students, did the same rotations that they did. And in 1988 or 89, I think it is, I decided, I was so inspired by this profession, thinking back to my Yellowknife and Fort Smith days. I was so inspired by this, what I was learning and what this profession represented. I wrote a letter to Perrin Beatty, at the time was the Minister of Health and Welfare in Canada. And I sent him a bunch of pamphlets. And I said, you need to look at this, take a peek at this. And I thought I'd never hear from the man. And about 3-4 months later, I get a letter from him, from his office. And in that letter, it stated, thank you so much for this information. I'm going to make copies and pass it out to all the provincial and territorial health departments, because they're the ones that make decisions about healthcare for their province and territory. And that was the end of it. I never heard back from anybody after that. But then I saw the PA profession starting to sort of take root in Canada. So there was some steps in the right direction. I had a thing I looked on cbc.ca a couple of weeks ago, and there was a big article about the healthcare crisis in Canada. I don't know if any of you saw it, but it's a real issue of concern. How many of you perceive there to be a healthcare issue of concern in this country, right? Many of you, right? There's not enough providers, right? So if you don't have enough of something, what do? We look for solutions. We either train more of the people that we need to get, right? We either train more people or we come up with an alternative solution, that can help fill in the gaps where there is need. And so there is a tremendous crisis in healthcare in Canada, critical shortage of family medicine physicians and other healthcare providers. And when I was visiting my brother Dave in Nova Scotia, maybe 7 or 8 years ago, he was having some serious health issues at the time, and he needed to be seen. There was nobody to see him. The local hospital in the area that he lived in, they only had ER coverage when they could get somebody to come from some other area. They didn't have enough people to cover the emergency room. Then the family medicine services were minimal at the time. This is in Nova Scotia, it's in rural Nova Scotia, but still, not like it's up in Yellowknife or way out in the bush. But anyway, there was not enough people to provide the care, right? So that obviously at that time I found myself again thinking, okay, they need PAs in these areas. They need to get some PAs or nurse practitioners in these areas to start providing quality healthcare service. So critical shortage of physicians and other healthcare providers. They were working, the docs, there was articles in the paper in Nova Scotia. They're working too long. They're too stressed. They can't manage, the volumes of patients, because there's too few of them, right? So you get the picture. Too much stress, long hours, tremendous pressure, burnout in their jobs, right? And I can attest to the fact that there's burnout because 15,000 of them fled to the United States in the 80s and 90s to come to the States where the grass is greener on the other side of the border. And I saw it. I've met them. I worked with these people. These physicians who were trained in Canada but came to the States because they couldn't handle it up here. And so there was a tremendous shortage. So, and as I mentioned, most of the and 50 PA programs in the country, and then now there's 300. Amazing. The demand is amazing. So in Canada, the PA profession it's a ripe time for the PA profession here in this country. Why hasn't it happened? Well, there have been turf wars in medicine. Probably not a surprise to many of you, right? I mean, when I was in the States, there were turf wars between MDs and DOs. DOs are doctors of osteopathic medicine. They're interchangeable with MDs. Okay, but 20 years ago, 25, 30 years ago, when I was working in New Hampshire, they wouldn't hire a DO if their life depended on it. A hospital. DOs had a real struggle trying to get into the profession, get themselves entrenched in the system. There have been turf wars between MDs and DOs. There have been turf wars between the MD lobby and also naturopaths, NDs. And so I put question marks. Could that be an issue with the establishment of the PA profession in Canada? That MDs have a strong hold on the system. They have a strong investment, let's say, on the system in this country. And so welcoming a new player into the system can sometimes be difficult. It's not good or bad. It's just the way it is, right? And so, but it can cause maybe put up some barriers. So you look at what PA training is how it's set up. It's fashioned after the MD program. It's fashioned after MD training. So PAs, they have previous medical experience to be accepted into the program. I was a nurse. Others are medical techs. Others radiology techs. You name it. We've even had physicians from other countries who didn't want to go into residencies, and they wanted to get into the PA, see the PA model. They think, gosh, I could do that. And they have to come and do the same training as the PA. They don't get any special benefit of skipping things. They have to come and start through the whole PA profession, the whole education, didactic training, and then they can graduate as a PA. So we've had physicians from Ecuador, we've had physicians from Vietnam, we've had physicians from India, all over the world who come and choose that route rather than to try to compete for a residential position. 27 months of rigorous medical education, clinical rotations and all the typical rotations that you would expect for a physician, like pediatrics, internal medicine, surgery, OBGYN, and so on, family medicine. PAs graduate with a master's in PA studies. So they're master's level trained medical providers. Or they'll get what they call a master's of medical science, MMS. But the way I describe them, they used to be known as mid-level providers. I don't like the name because they're really not mid-level of anything. They're advanced practice medical practitioners is probably the more accurate way to describe them. I mean, they have a master's level of education, medical education and training on top of all their previous education. So it's like the professor and your associate professor sort of relationship. Maybe they're not the full professor, but they have associate professor status and they can teach all the material that needs to be taught. They can do all the same things in most cases that a general family practice or general practitioner can do, right? And they can't take your appendix out. You wouldn't want them to take, but a family physician can't take your appendix out, even though they might have been trained, right? PAs, when they function within the scope of their practice at the top of their license, a PA can be a very effective colleague to physicians, especially in rural or inner city areas where maybe some physicians are not accessible or don't want to live. So the PA concept has a lot of weight and a lot of strength to it. Like physicians, they have to get CME, which is continuing medical education, 100 hours every 2 years, right? Going to conferences, sitting in on lectures, doing journal reading and other things. And then they have to take national board exams every 10 years, just like their physician colleagues, right? So the training was designed very much like docs, like physicians, right? But it was the core content was abridged. There were certain things that they thought they didn't have to include in there, and I could go into all that. I won't because it's just nitpicking little things, right? But the point is they took the essence of 4 years of medical school and condensed it down into the core content of it down into 24 months is what basically has happened. So that's the sort of the education for PAs. So the seeking points of agreement. So as I just mentioned, the physician and PA model are very similar, right? They're very similar. So that's one point of strength, I think. The healthcare workforce diversification, this idea of horizontal substitution is a reality. And I'm living example, I'm living proof of it, standing before you. And what that means is that many skills and talents that physicians only used to possess and offer to their patients were then horizontally shifted onto other professions, nurse practitioners being one, and PAs now being another for the last 60 plus years. A lot of those basic talents and skills that physicians learned, then suddenly got shifted over horizontally to other professions because docs, they didn't have enough time for all of it. They were too overwhelmed with patients. Well, we need to get some other people in here to help, and we'll shift some of these responsibilities onto their shoulders. And so PAs and nurse practitioners have sort of filled that role, right? So what does the family doc do? They come in, they see a patient, they do a medical history, they order labs, they do referrals, they prescribe medications. Well, PAs do the exact same thing. Nurse practitioners within their scope do the same thing, right? So So they've had this thing called horizontal substitution, where responsibilities have now been shifted to other medical providers. And in a minute, I'll share what I think what I think is important about that, and that, especially from the fact that if we see them as competition, it's not going to work. It's going to be really challenging. But if we see them as colleagues, if physicians look at PAs as colleagues who can really help and make their life better, then all of a sudden a lot of the barriers that might seem evident disappear, right? So more on that in just a minute. So well-trained PAs are really good generalists. Let's see, what else did I put up there? Well-trained PAs can capably see 80 to 85% of what most family docs can see. I've sort of alluded to that. PAs, like their physician counterparts, get specialty training in advanced trauma life support, advanced cardiac life support, advanced OB life support, you name it. PAs do the same specialty training that their physician colleagues do. And so why does it work? Because physicians and PAs have learned to work collaboratively together. That's a key part, right? If one welcomes others into the sandbox to play nicely, right, all of a sudden everything seems to work really well. But when people sort of are possessive of the turf, it makes it more challenging, right? So PAs and docs have worked well in the United States. Believe me, the first 20 plus years was challenging. 30 years was very challenging. And even when I graduated, it was a challenge for the first decade or so. But all of a sudden, many of the new doctors being trained, physicians being trained in the States, had worked and been trained by PAs. And so all of a sudden they knew who PAs were, and then it shifted. Malcolm Gladwell, it tipped, right? For those who have read The Tipping Point. It tipped, everything tipped, and then PAs were welcomed much more openly into the medical system by their physician colleagues. So it works well because of that. Because physicians accept them as valuable colleagues and knowledgeable and capable providers. Let's see, what else did I have there? Yeah, the idea of a transdisciplinary team, multiple different professions working together for patient-centered care. This in the States, I don't know about in Canada right now, but in the States, patient-centered care are the watchwords of care. When you go to see your provider, your primary provider, your PCP, right? Well, if you need to see the OT, you need to see PT, you need to see a specialist. Everybody works together to make with you at the center of the care diagram, right? And so it works when PAs are part of that, or nurse practitioners. It works because they're part of that transdisciplinary team and they're accepted. They're respected and accepted that they will work at the top of their license within the scope of their practice, just like any physician or anybody else, right? So that's a key point, I think. Let's see. So barriers to success: lack of vision, short-sightedness, unable to see the forest for the trees. In other words, not looking at the PA as a valuable contributor to high-quality healthcare within a system like Canada or the States, right? So that's certainly a barrier. If people are unwilling to look at it, if there's a problem, right, one has to be open-minded enough to look for solutions wherever they may be, right, and to consider them. Well, that's just not going to work. Okay, that doesn't work. What else? This thing. Okay, let's look at that. And so if people are unwilling to look at solutions, it's going to be a challenge. That's one thing. Ego. I don't want to play nicely with others in the healthcare sandbox. Again, as I sort of alluded to that if it's a barrier, if people are unwilling to consider options other than what has been the standard for 100 years, it's going to be a challenge, right? Politics, professional associations hindering the growth of the PA profession. It happened in the States. There were lobbyists, from other health organizations that lobbied against PAs, that lobbied against nurses, that lobbied against physicians. So when people do that, they try to use politics to suppress, right? It's going to be a challenge. There are barriers there, and so that has to be considered. That's one barrier. Another barrier: unwillingness to acknowledge the talents of non-physician advanced practice providers. That's a big one. If a physician is unwilling to acknowledge that, say you or whomever, as a PA or a nurse practitioner, that you have enough professional ability to treat a strep throat, or just treat a whatever, right? Then there's going to be that's a barrier to success, right? So there has to be acceptance of the training and respect for and understanding of the training of the different professionals that are part of the team, right? And then with that understanding comes acceptance and respect for each of the players. That's critical, right? But without it, it's a barrier. Without it, it's a barrier to success, I think. Unwillingness to be a team player, same sort of concept. Lack of respect for the knowledge and contributions of others. That and we could go on. The list could go on. So I think the benefits for here in Canada, to wrap up, I think is access to care. Number one, here is a viable, highly respected model in the States now that has really taken foothold in the States, that now has 1,000 PAs working in Canada, but still is under the surface, under the current, in a sense. And, this model is here, and so those that are in positions of responsibility and authority in your districts, in your ridings and so on, is to put the word out. If you think we need solutions to our healthcare crisis, well, here's one, and how does it get done? It gets done by people out in the trenches, in the grassroots, talking to their representatives and saying, look, why don't you look into this and see how this could play a role here? And so most of the PAs around are in Ontario. I think out of the 1,000, there's probably 600 or so here. So many out in Manitoba and some out in BC as well. But Ontario has a large population. PAs represent high quality healthcare providers. They're well trained. They're master's level advanced practice practitioners, right? And for what they've been trained for, they're very good at it, right? You're not going to go and see them to take your appendix out, like I said, but you'll go to them for 85, 90%. They can take care of what most family general practitioners can take care of. Cost effective. You can train 2 or 3 PAs for one physician. So you can get a couple, 2 or 3 PAs out into the system, out into the public, for every doc that gets trained. Now, I'm not advocating that we stop training physicians. We need physicians, and PAs we used to call them partners, capital PA partners, right? Partners in healthcare. They work together as colleagues. And in the States, it's been working very effectively in the last, 40 years especially. This whole partnership, team-oriented model of healthcare. This is where healthcare is now. It's no longer individual sport. It's a team sport. Right? And so having colleagues to work together to take on responsibilities is critical. 60 years in the States of success, win-win partnership for the physicians here in Canada. The workload will be managed more effectively. Stress levels, burden, job satisfaction, all of these elements, have the potential to be addressed really significantly. And physicians have a much more meaningful practice of medicine and a balance between their practice and their lifestyle, their home life. Let's see, I think I've touched on these other things. So just to wrap up then, I would say that, the PA profession is already here in the country. It's still sort of hovering below the surface. As evidence when Alan asked the question, how many of you know about PAs? Only one person, and that was one person who actually had been in the States. So you need to know, my fellow Canadians, that there are PAs in this country. The profession is already rooted here. It's established. What needs to happen now is for the profession to grow and to blossom here and flourish in this country. And if it happens, you'll be getting, as patients, you'll be getting highly trained, quality, advanced practice providers, and the physicians who are here already will be getting colleagues, supportive colleagues, who will extend their services to the patients in a highly professional and quality health fashion. So that's all I will offer at this point, and I'll leave it there. Any questions or maybe? Yeah, a million questions. Yeah.
Okay, Jim. Well, yeah,
Yep.
We'll have questions after.
After, yes. Yep, good. Thanks.